discussing on the elimination of lymphatic filariasis, particularly on the strategies and then targets and the new approach and monitoring and evaluation. So this are the lymphatic filarial parasites which have been identified in the human system. One is Wuchereria bancrofti. This is as we know, there are three human filarial parasites: Wuchereria bancrofti, Brucia malai, and Brucia timori. These are the three parasites cause lymphatic filariasis in human. The Wuchereria bancrofti has the wide distribution. It's responsible for about 98% of the total infection due to lymphatic filariasis. And Brucia malai and Brucia timori, they are restricted in distribution, particularly in Indonesia, and of course few packets we have in India. And timori is limited to only Indonesia. And of course, all our identifications are based on microfilaria, because that's the one stage what we get in the blood system. Adults live in the lymphatic system, so it will be very difficult to retrieve. And all our identification and the description of the species are based on the features of the microfilaria. And the adult parasites, the females are quite longer. It's about 6 centimeters. And both males and female, they just live in the lymphatic system and makes the lymphatic vessels dilated, and that leads to the lymphedema. That is the clinical consequence of the infection. And coming to the vector, and there are at least 10 species of mosquitoes that transmit the lymphatic filariasis. So we have the parasite and the vector different combinations. So a single method may not be possible to control or eliminate this particular infection unless otherwise we target the parasite. So if you see the vector and then the parasite combination, though we have 3 filarial parasites, so there further it has been categorized into different physiological races depending on the characteristic features of appearance of microfilaria in the bloodstream. So periodic and subperiodic. So periodic is that it's restricted to say a particular period of time in a day, and subperiodic means it's available throughout 24 hours. So here we have Anopheles vectors, and the vectors of periodic Brucia malai, timori, and Wuchereria bancrofti. And this is particularly prevalent in the African countries and also in the Indonesian islands. And Aedes vectors are responsible for the transmission of subperiodic Brucia malai and Wuchereria bancrofti. And we know that Aedes vectors, they are day biters, and the appearance of the microfilaria of these parasites during the daytime, they transmit this particular infection. Then Culex vectors of nocturnal periodic Wuchereria bancrofti, as I mentioned, this is the wide distribution, contributing about 98% of the total infection. So the major vector is the Culex vector for the transmission of filariasis. And we do have Mansonia vectors, and that's particularly for Brucia malai, and also subperiodic Wuchereria bancrofti. That's, of course, again, it's not in India, but it's in the other Southeast Asian countries. And the other thing, again, Aedes vector, that's for non-periodic Wuchereria bancrofti. And in India, we have a lone foci of this non-periodic Wuchereria bancrofti, where the microfilaria will appear throughout the 24 hours. But the peak will be during the daytime, and the mosquitoes, the day-biting mosquitoes, transmit the disease in a few islands in the Andaman Nicobar Islands. So because of these the different combination of the vector and the parasite, the vector-based interventions will be very difficult, in the sense that is, unless you have vector-specific interventions, it will be difficult to control. But at the same time, if you target the parasite, and if you have some drug-based intervention, and that will be very useful to control the infection due to lymphatic filariasis. And as we know that the human is the only host for this filarial parasite, except one strain of Brucia malai, that is the subperiodic Brucia malai. So where we have the animal reservoirs, particularly the domestic cats and the dogs. So to control this particular infection, where you have the zoonotic nature of transmission, then of course the drug-based intervention will have certain limitations. Under that circumstances, vector control will be very useful. Of course, this infection ends up with the elephantiasis, is nothing but the lymphedema in the legs and also the hydrocele. Okay, then coming to the distribution of the lymphatic filariasis at the globally, and also look at the burden. It is prevalent in 83 countries, but indigenous transmission have been reported in 72 countries, and particularly these countries are in the tropical and subtropical region where the climatical conditions are favorable for the vectors to breed and then transmit the infection. And then in Southeast Asia region, there are 11 countries. And out of these 11 countries, 9 countries are endemic for lymphatic filariasis. And in this region, 119 million people are infected. It means this is a total burden globally, and out of which 50% from the Southeast Asian region. And 1.39 billion people are at the risk of infection worldwide. And from Southeast Asia region, where of course India is also one of the countries in the region, 63% of the burden is, I mean, the risk of people are living in Southeast Asia region. And of course, as we know that this disease after the infection that leads to the lymphedema, and it becomes a kind of an irreversible condition even with the medication, and that leads to long-term disability. So this is actually, it's a chronic disease, and though it doesn't cause any mortality, but the morbidity is so much. And if it is measured in terms of the burden, it's, if it is measured in terms of the burden, that's the normal summary measure the DALI is used, because the infections cause a different clinical outcome. Some cause mortality, and some cause morbidity, and some cause disability. So combining all these three outcome of the infection, then a summary measure has been developed, that is the disability adjusters life years last because of this infection. And it has been estimated that 5.3 million DALIs are lost per year due to lymphatic filariasis in the WHO region. And if you see that 61% of the burden is from Southeast Asian region. Similarly, if you just look at the risk of the people living at the risk of infection in the WHO region, it is 1.2 billion people are at the risk of infection. Again, 62% are from Southeast Asian region. So it means whatever the achievement we reach due to control or elimination program, if we are successful in Southeast Asian regions, and largely we can achieve the elimination in the global level. So this is the burden of lymphatic filariasis in India. This was estimated in 2007. And if you see the total, the DALIs, that is the disability adjusted life years last, is 4.2 million, of which the lymphatic filariasis constitutes about 41%. It means about half of the burden due to the vector-borne diseases. The lymphatic filariasis is the burden due to lymphatic filariasis is a maximum. This is mainly because of the long-term morbidity, and particularly the disability, which leads to this level of the burden, so that it becomes a kind of a priority area of the control for the program. So this is the life cycle. I think probably Dr. Hoti has shared this life cycle. Now I'm showing this life cycle because now we have to identify the point of intervention for the control of transmission, and of course finally the control of the disease. So in fact we have two major ones. Number one is the host, the parasite in the host, and another is the transmitter, nothing but the vector. So we can intervene, but where to intervene, that we have to decide. So we have to see that what are the options we have to intervene, whether vector-based intervention or parasite-based intervention. And again, parasite-based intervention, it can be a case detection and treatment, or we can go by mass chemotherapy. So these are the options we have. And in subsequent slides, we can see that what is the weakest point of intervention. So this is again the diagnostics available. I think Dr. Hoti covered on that. So what is important I want to mention in this is that in recent times we have the point of care diagnostics, which can be used in the program, and also which is highly sensitive, and it also measures the kind of the infection, not the microfilaria. So it means even the people having infection without microfilaria, it can be detected by using the sensitive antigen and antibody test. And this is in fact now it's being used in the program to make a decision on stopping mass drug administration. And this this is the elimination strategies which have been recommended by the WHO. So LF has been identified as one of the 6 diseases that has, as potentially eradicable. It means that we have strategies, we have options, and which, if we implement it, then we'll be able to achieve the control and the elimination. So that is the first thing which has led to the development of the strategies. And subsequently, looking at the strategies for eliminating lymphatic filariasis, the World Health Assembly passed a resolution in 1997 that it can be eliminated, and LF elimination as a public health problem by 2020. So this was the target set by the WHO at that point of time. That was in 1997. And also it urges the member states, it means the countries wherever you have the disease, the lymphatic filariasis, to strengthen activities towards eliminating lymphatic filariasis as a public health problem, and also request the Director General to mobilize support for global and national elimination activities, particularly networking with the stakeholders or the partners. Then, of course, subsequently what happened is that, of course, many countries, they have achieved the elimination, but larger countries, still they have to achieve the elimination. And now, of course, under the concept of neglected tropical diseases, and now this lymphatic filariasis have been realigned, and the target of elimination has been realigned as 2030. And as far as India is concerned, of course, we have the National Health Policy, that was 2002. And in that National Health Policy, elimination of lymphatic filariasis was targeted by 2015. And now, of course, the new target, it has been fixed as 2021. And probably that we have the strategies to achieve the target by 2030 as the NTD target. So now the elimination as a public health problem, this is what it is defined. So it means, why elimination as a public health problem? Infection will be there, maybe at the very low level, but at the same time it will not lead to any kind of the public health problem. It means without any new cases of morbidity. So that is the objective. So infection will be there, but it will be at very low level, but that should not lead to some kind of morbidity. So that the target, as I mentioned, initially it was 2020, and then 2030 was the NTD target, and where LF is also one of the neglected tropical diseases. And the strategies what include here is that once the 1997, the WHO Health Assembly resolved the resolution, and it developed the program, the protocol for eliminating the disease. What is it? Global Program to Eliminate Lymphatic Filariasis. That was developed in 2000, and the global program was launched by the WHO in 2000. And it has 2 major strategies. And at that point of time, the Global Alliance to Eliminate Lymphatic Filariasis was formed, and then that really extended the support for achieving the elimination. So in that global program for eliminating lymphatic filariasis, the strategies are 2. Number 1 is that stop transmission with mass drug administration, that is MDA, and reduce the suffering of already affected people, and improve the quality of life, that is called morbidity management and disability prevention. So these are the 2 pillars of the program. And under stop transmission through the mass drug administration, what we call it as preventive chemotherapy, the recommendation is that provide the treatment to all the eligible population once yearly with a single dose of 2 drugs for 4 to 6 years. That's with the diethylcopysamine, that is 6 mg per kg body weight, and 400 mg of albendazole as a flat dose. So this combination of the drug is given every year, and then this is for 4 to 6 years, because the fecundate lifespan of the adult worm is 6 to 4 years. So unless otherwise you continue this treatment for these many years, it will not be possible to achieve elimination. So here the principle is that once the treatment is given to the community, and if you achieve the recommended coverage level, then it should be possible to reduce the parasite load in the community, and thereby we can prevent or interrupt the transmission. So that is the basic principle of mass drug administration. And the other option it has recommended is that the exclusive use of table salt or cooking salt fortified with the DEC, and I mean, the use for 1 to 2 years with the concentration of 0.2% by weight. So the progress, if you just look at, as I mentioned, that in 2000 this program was launched by the WHO, and the countries have started initiating this program at different points of time. And in 2019, out of 72 countries where the program to eliminate lymphatic filariasis was required, 69 countries have already started this program, and they have started implementing master administration with the two drugs, diethylcopysamine and albendazole. And so far, if you see that the cumulative total treatment of these two drugs in these 69 countries, it is about 8.6 billion treatments, and reaching more than 910 million people. So this is at the global level, the progress of the program. Then, of course, if you just look at the effect of the drugs or impact of the drug on the parasite, as we know in the transmission cycle, so we have the adult worm, which lives in the lymphatic system, that produces microfilaria that comes to the blood system. So these are the two different stages which you see in the host, in the human host. And then by giving the drugs, of course, we can target these parasites, these two stages of the parasites. So we have albendazole. This albendazole is known to have some effect on damaging the parasite. Of course, not fully. It doesn't kill the parasite. And also, it has the capacity to reduce the reproductive capabilities of the adult worm. So this is the effect of the albendazole on lymphatic filariasis. In addition to, we have the collateral benefit of the clearing the intestinal worms. And then coming to microfilaria stage, of course, we have the diethylcopysamine, which eliminates the microfilaria and reduces the circulating the microfilaria in the blood. So here the mode of action, if you see with the diethylcopysamine, it acts through the immune system. It means that the barrier of the microfilaria, that we have a sheath in the microfilaria, which is not only the physical barrier, but also immunological barrier. So that barrier really, makes the parasite evade from the immune system in the human, and diethylcopysamine sensitizes the microfilaria so that the microfilaria gets cleared from the bloodstream. So if you see the landmarks towards elimination, 1992, filariasis was identified as eliminable. As I mentioned, out of 6 the diseases has the potential strategy for elimination. And 1994, of course, WHO declared the revised strategy. And 96, of course, India, the first country which launched a mass annual single dose of diethylcopysamine in a pilot scale in 13 districts. And in 1997, WHO World Health Assembly passed a resolution on elimination of lymphatic filariasis. And in 1999, the GSK declared a free donation of albendazole for LF elimination program, because as we are aware, the albendazole is very expensive, and maybe particularly in developing countries, there may not be possible for mobilizing the sufficient fund for that. So now the GSK, which is the major manufacturer of albendazole, as it came forward to donate the required number of the drugs to all the endemic countries wherever this program was launched. So this was really a good support for the program and for the countries to initiate this. And in 2000, of course, the Global Alliance for Elimination of Lymphatic Filariasis was formed. This actually provides both technical support and as well as the financial support to the countries, and also conduct every year the annual meetings on the reviews, and also update all the technical informations on this. So this was really a kind of a continuous support for the countries to take forward the program. And 2002, India formed the National Task Force, and in fact, it started piloting, the co-administration of albendazole with DEC, because though the WHO initially stated the co-administration of the 2 drugs, and of course, India wanted to have its own pilot scale trials, and based on the results, then the India was planning to expand to other areas. So it was done in 8 districts, and based on that. In 2002, the India declared the elimination program, I mean, launched the elimination program, and also keeping that national target of eliminating by 2015. 2004, of course, it extended to 202 districts in 20 states and union territories, and 2006 expanded to 243 districts at that point of time. In fact, these many districts were identified as endemic for lymphatic filariasis. And then in 2007, so based on the results from the pilot scale trials in India and with the co-administration of albendazole and DEC, and the Ministry of Health recommended use of albendazole along with the DEC for the must-take administration in India. In 2009, of course, national guideline on lymphatic filariasis was developed, and then 2017, accelerated plan for lymphatic filariasis elimination was developed, and it was made available for all the program managers for planning their program. So based on the advancements in the strategies. And 2018, of course, the triple drug regimen was introduced. It means DEC plus albendazole and ivermectin is also added based on certain trials in India and elsewhere in different countries. So this is so far, if you just look at the number of treatments at the global level provided for eliminating lymphatic filariasis in 69 countries, because as I mentioned, so 69 out of 72 countries have started the program. 8.6 billion treatments have been given. It means that annually the targeted treatments, and then up to 2020, it means 20 years, 8.6 billion treatments have been given with the DEC and albendazole. And now the benefit of the program, if you see that 692 million people, I mean the people who are at the risk of infection, no longer requiring must-take administration, and that is in 44 countries. So if you see that there is a reduction of the population who are at the risk of infection was about 50%. So this is the status or the progress of the lymphatic filariasis elimination program as on 2021. See, out of the 72 countries, if you classify that, the MDA not started is 3 countries, and the MDA started but not at scale, in the sense not at the national level. Only few the districts or the implementation units were covered under must-take administration, but the number of countries where the entire country was covered, that is in terms of the areas with the disease. So 37 countries now, they have started at the national level the program to eliminate lymphatic filariasis. And then 8 countries, they have started the program, and also now they have stopped. So based on the transmission assessment survey and showing that reaching the elimination of the lymphatic filariasis, now they stopped MDA, and it is under post MDA surveillance. And if you see that 17 countries already, they have achieved the elimination, in the sense that they have demonstrated that there is no resurgence of infection after the stopping MDA, and the WHO has acknowledged the claim of elimination of lymphatic filariasis as a public health problem in these 17 countries. So now, if you're coming to the Southeast Asian region, of course, where, of course, India is one of the countries in that, 3 countries have already achieved the elimination of lymphatic filariasis as a public health problem: Maldives, Sri Lanka, and Thailand. And Bangladesh, it stopped, and then, of course, it's going to submit its dossier for the WHO to acknowledge that claim of elimination. But rest of the countries like India, Indonesia, then Myanmar, Nepal, and Timor-Leste, these are the countries, in fact, still they have, they are continuing this must-take administration. They have not achieved the elimination in all the endemic districts. So, but what they have done in these countries, in fact, at the national level, they have scaled up and they have covered all the endemic areas. So this is the progress, and not only at the global level, at the regional level also. So we have examples or of elimination of the lymphatic filariasis through must-take administration with the 2 drugs. So this is the status now. If you see the impact of the program to eliminate lymphatic filariasis, a global program, as I mentioned, it was started in 2000, and at that point of time, the burden was estimated in terms of disability adjusted life years. It was 5.255 million. So after the program, after 17 years of implementation of this program in these countries, and it was brought down to 1.3 the DALYs, million DALYs lost due to lymphatic filariasis. This is a great achievement, and this is a benefit of the program. Thereby, the burden in terms of the DALY has been achieved. So then coming to the situation in India, the current status is that earlier, of course, we started with the 243 districts, based on the historical information. But now new districts have been identified to be endemic. So based on the line listing of cases and subsequent assessment of infection in certain the hotspots, and new districts have been added. Now, as on date, of course, 328 districts have been identified to be endemic for lymphatic filariasis in India. And of course, still there may be few districts that which awaits the final, the assessment of the situation. So probably there may be few more districts to be added to that. So out of this, the transmission assessment survey, which is one of the decision-making tool, was implemented, and then based on that, the decision of stopping MDA was taken. So 132 districts, have achieved the elimination level, but actually this has to be continued for 5 more years. It means that repeating the task 2 more times after the first toss. So it means at least 132 districts no longer require master administration. Then the remaining districts, 195 districts, of course, the MDA is being continued. So you have to remember many countries that many districts, more than 15, 16 rounds of master administration is being implemented and is being continued. And this is mainly because of suboptimal impact, and this suboptimal impacts are mainly related to suboptimal coverage. So coverage is a major issue where it limits the impact of master administration. And now out of this 195 districts, and India is the largest consumer of the ivermectin, because the triple drug, the ivermectin, diethylcopaxamine, and albendazole, short it's known as IDA. These three drugs is being implemented in 22 districts, covering about 67 million. In the remaining districts, 173 districts, covering about 387 million with the 2 drugs. Slowly, this the idea is being expanded to other districts, particularly the hardcore districts. So now the new plan for 2022, additionally 31 districts have been identified. So put together, there will be 52 districts which are under the triple drug strategy, and with about 109 million people under this IDA. So the second component or second pillar of elimination is the morbidity management and disability prevention. And the minimum package for this particular strategy, as per the WHO, is that it should have 100% geographical coverage. It means that every individual having the chronic manifestation has to be covered under this program. So again, the health facilities at every district with known patients must be able to provide treatment of acute attacks, and then management of lymphedema, management or surgical correction of hydrocele, and also treatment of lymphatic filarial infection. Then, of course, as we know that the adult worm lives in the lymphatic system, and it makes the dilation of the lymphatics, and that leads to some kind of permanent damage to the lymphatics, and that leads to the irreversible clinical manifestation of the lymphedema. The main reason is that the bacterial infection which enters through the lesions in the skin of the elephantoid leg, and that leads to the fever, and that repeated what we call it as the the lymphatic fever, and that leads to the lymphedema. Then, of course, the recurrent infection, it's a bacterial or fungal infection, either external or internal in the lymphatics, that leads to elephantiasis. So that has to be taken care, and this minimum package has to be there in the elimination of lymphatic filariasis program. So this is actually the kind of the review, systematic review on the coverage and the complaints of master administration in India. So in fact, this database from 38 districts, it was done by an independent agencies like medical colleges. And if you see that, so what we expect is that the target coverage is 80%. It means the drug should reach at least 80% of the people in the implementation unit. That is the eligible population. And if you see that, the review shows that out of 28 the districts, I mean the rural and urban area, and then 18 districts are below that the target of 80%. So it means these districts require improvement in the delivery of the drugs. So similarly, if you see the consumption, because the consumption is very important, it's not that outreaching the people, I mean the people should consume the drug. So that's very important. And the target is the WHO recommended at least we should have 65% coverage. So if you see the coverage levels in these districts, out of 29 districts, 21 districts is below 65% coverage. So this is one thing, this is a major concern. Unless otherwise we ensure minimum 65% coverage in the sense consumption, then it will be difficult to achieve. This is the minimum level, the coverage level is required. Unless otherwise you achieve this level, it would be difficult. We cannot expect any impact on the transmission. So then, of course, the new strategies, because what we have seen is that the two drugs, diethylcobalamin and albendazole, and subsequently there were some studies carried out, the clinical trials carried out, adding one more drug, ivermectin, to these two drugs, DEC and albendazole. So the pilot study on safety, efficacy, and pharmacokinetics was conducted in 2 countries, in Papua New Guinea and also the Devote. And subsequently, the community-based safety and acceptability studies were conducted in 4 countries: Haiti, India, Indonesia, and PNG. And the India study was undertaken by in the one of the districts in Karnataka. So that formed as a major data for the WHO on the safety. So when you just look at the ivermectin, so it is highly effective microfilaril drug. It's like a diethylcobalamin, and it has additional effect. It's that inhibiting the adult worm from releasing the additional microfilaria. So it means that it has kind of a suppression on the production of microfilaria by the adult worm. So that is the advantage. So that once the treatment is given, and albendazole takes care of limiting, the production of microfilaria by the adult. Then half-life, it's like a DEC, it's 12 to 36 hours, and effective against a wide range of parasites like roundworms, then lungworms, mites, and the lice and hornflies, so that it has got some collateral benefit. And it also, like these, it has got an indirect mode of action. It suppresses the ability of the parasite to secrete the protein that enables the parasite to evade human immune defense mechanism. So since the mode of action is indirect, then of course we cannot expect for any kind of possibility of the parasite developing resistance to this particular drug, so that it can be safely used in the master programs. Then, of course, ivermectin is being used in onchocerciasis control program for many years, for decades, we should say that. But still, of course, there is no report of any resistance to this particular drug. And again, this was registered for treatment for lymphatic filariasis in 1998. And these 2 drugs, in fact, have been used for the elimination of lymphatic filariasis, particularly whenever LF is co-endemic with onchocerciasis, because when LF is co-endemic with onchocerciasis or OSS, what will happen is your adverse reaction will be higher, so that the ivermectin is used in place of lymphatic filariasis. And then it has been designated as an antifilaral drug in the WHO model list of essential medicines. Then, of course, it benefits millions of people throughout the world through onchocerciasis program, and also for the control of lymphatic filariasis. And in India, it is a registered drug, and it can be used as a oral medication for the treatment of lymphatic filariasis. So these are some of the features of the ivermectin, so which is really adding strength to the master drug administration program. So this is one of the clinical trial carried out in Papua New Guinea. In fact, following a single treatment of three drugs, ivermectin, diethylcobalamin, and albendazole. So these patients were followed for 3 years. So every year, they were checked for the microfilaria. So if you see that, that's a 3-drug regimen administered once with a single dose, 96% after 1 year. And then this was continued for 3 years with a single dose. It means, so whatever the suppression test made after the first round of treatment, it is maintained. So it means there is a permanent reduction in the microfilaria, and that's really leads to the interruption of the transmission. Of course, with the 2 drugs, it's only 56%. And this is again after 1 round of MDA. But the same 2 drugs is given for 3 years. If you see that, of course, 98%. So that it shows that the 2 to 3 rounds of MDA would be sufficient enough to keep the microfilaria load under control. So the IDA 3 drug is 40% more clearance in microfilariemia and sustained measured impact for 3 years. And then, of course, inhibits release of microfilaria, and pharmacokinetics shows that there is no interaction between DEC and ivermectin. Then, of course, we have additional benefits like collateral benefits on other diseases. So this is actually, this study was continued for another 2 more years. And then if you see that the reduction in microfilariemia, it means the clearance rate, whatever observed after 1 year, is maintained. So when you see that only 2.8% of the treated people had the microfilariemia, so it means that the reduction is sustained with a single dose. But at the same time, if you look at the antigen positivity among these people, and there was only 25% reduction in antigen prevalence, may be related to the natural loss of infection. So it means, it clearly shows that the action, even if you give 3 drugs, the action is more on microfilaria, and also its suppression of the production of microfilaria, but it doesn't kill or clears the adult worm. But what we are looking for is only this effect. It means that the parasite load in terms of microfilaria, that infective stage from the human, should be suppressed, and make the vector not transmitting. It means not available, the parasite not available for the vector to transmit. So this is the kind of the evidence which has given strength to the WHO for recommending this for a new strategy for the elimination of lymphatic filariasis. So this was the result of the study conducted by the Vector Control Research Center in one of the districts in Karnataka. So here, if you see if the clearance rate, it is nothing but the efficacy. It means a single dose of the 3 drugs, 84% clearance after one year, after 1 round of MDA. But at the same time, the DA, so it was about 54%. So this additional effect is about 22%. It means 22% more efficacy is when you give 3 drugs when compared with the 2 drugs. So the other thing also, this is the previous one was on efficacy, following the cohort of the positives and looking at the clearance and also the sustainability of the clearance in the cohort of positives. And at the cross-sectional level, at the village level, the effectiveness was assessed, and it showed that the microfilaria prevalence after 1 round of MDA with about 70% coverage, there was about a 48% reduction in the prevalence, from 6.8% to 3.5% reduction. And in case of the 2 drugs, it was only 13% reduction. Of course, the cumulative effect of 5 rounds, definitely it will lead to a more reduction in the MR prevalence. But with the single round, 50% of the cases, they became negative. So this is the advantage of triple drugs. And also the intensity, it means that is the parasite load is also reduced. It's about 53% after 1 round of MDA, whereas it's about 19% with the 2 drugs. So it means it is more effective, and also our study have shown that it is more acceptable to the community, though we add number of drugs and the pills for the community to consume. So when I just look at the role of this triple drug in the transmission, the control of the transmission, as I mentioned, that again, preventive chemotherapy targeting the parasite stages, both adult and microfilaria. This albendazole effect is already known, but when you add the ivermectin to DEC and albendazole, then not only it kills or clears the microfilaria, whatever present in the bloodstream, but reduces the circulating microfilaria in the blood, in the sense that it has certain inhibitory action on the adult form in releasing the microfilaria. So this is the one which really we expect, and that really leads to the interruption of the transmission. And of course, when you have good coverage, so that leads to, within few rounds of MDA, total interruption of transmission. So but when you think of the three drugs, so these are the things which we have to consider. Definitely IDA is more efficacious and more effective, and also no safety concern, in the sense that the safety level is comparable with the two drugs. So adding one more drug, it does not cause any safety concern. And also it's feasible to implement. So we are adding one more drug to the existing two drugs. But what is important, it is not a replacement for poor coverage or poor delivery of the drugs. This is very important. So high level of coverage, high level of compliance have to be maintained. So these are the collateral benefits which I have mentioned, because as we know, in India, 225 million preschool and the school age children are at the risk of the soil transmitted helminthiasis. And albendazole, as you know, that it has effect on this. And then this burden is about 65% in the Southeast Asian region. That is the burden in India, and globally it is 27%. So it means the burden due to the STH is very high. And when you have the LF program with albendazole, so definitely it has got a collateral benefit of controlling this STH. So this is in addition to that. Of course, we do have the effect on the scabies and the head louse, and then of course this again is a collateral benefit. So based on these studies, particularly on the data on the safety profile of these three drugs generated in different countries, including India, and the WHO actually this they reviewed the results, and that review is based on the results or the evidence from over 10,000 treatments using this particular three drugs. Then, of course, it formulated the IDA strategy for countries not yet started or at scale with the MDA. Countries observing suboptimal responses. That what really we are seeing in India, in the sense that suboptimal means that still we are not able to achieve elimination. So these are the situations IDA is suitable. So now the recommendation of the WHO is that we can give annual three drug strategy in different settings, and particularly the settings where the implementation units that have not started or have fewer than 4 effective rounds, one, or maybe if you are not able to achieve the epidemiological targets. So particularly pre-TAS, what we are looking at is that less than 1% M prevalence, that was the target reduction. If you are not able to achieve that epidemiological target, that area can be considered. So similarly, if the TAS is not successful, that area can be, that districts can be considered for the three drugs. And also, because once you achieve the elimination level, because we have to remember, when you say elimination of lymphatic filariasis as a public health problem, some level of infection is allowed, in the sense automatically, even without the absence, without any control measure, automatically it dies off. So but because it's a clustered disease, there may be some hotspots. So even after stopping MDA, or even stopping after getting an acknowledgement of from WHO that achieving elimination, there may be certain areas or packets that there may be some resurgence of infection. So during the post MDA or post validation surveillance, so that situation, so that places like hotspot, so you can have this targeted approach. Treating that particular community with the three drugs. So this is the flow chart showing that the situations where IDA is suitable. Um, so then coming to the how many rounds of MDA has to be given. For example, as I mentioned, that DA is for 4 to 6 years. That actually based on the fecundal lifespan of the adult, because it doesn't have much effect on the adult. The adult will continuously producing microfilaria, and if you give the DEC reduces the microfilaria load, but doesn't stop the adult worm producing microfilaria. That's it. But here, since the effect of the three drugs, it means that whatever the clearance is achieved, then that is being maintained. So it means that it has certain effect on the adult in producing microfilaria. So based on that, there are some simulation models, and the studies have shown that 75% coverage could achieve elimination with the 3 rounds of IDA, unlike DA, where we have to give for 4 to 6 years. And then, of course, the Technical Advisory Committee of Ministry of Health and Family Welfare, Government of India, has recommended the strategy for accelerating LF elimination program in India. That was in 2018. So initially, 5 districts were identified for the triple drug regimen, and that was implemented in 2018. So this is an accelerated plan of 2018. Of course, the at least 12 actions have been recommended for accelerating LF elimination, and one of the action is that to introduce innovative preventive chemotherapy strategies. When you talk about innovative preventive chemotherapy strategies, IDA-based intervention is one of the innovative measures. Of course, we do have the DEC salt, which can be used as an additional or supplementary measure. So, of course, this is the dose which we know that the DEC is age standardized 1 to 2 years that we give 1 tablet, and 6 to 14 years we give 2 tablets, and above 14 years 3 tablets, and albendazole is a flat dose. And then coming to the ivermectin, so ivermectin is based on the weight, but this has been standardized according to the height of the individuals, and accordingly the number of tablets have been finalized. So this is a kind of the pole, which is a dosing pole, which is used for determining the number of tablets to be given. So then coming to the progress of the three drug based intervention in India. Of course, these are the states which have been identified, particularly the states having the hardcore areas of transmission. And 2 rounds have been completed by 2021 in 4 districts, and 1 round completed in 18 districts, and proposed in 22 districts. So altogether, so we have 44 districts which are under IDA ending 2020 and targeting about 109 million people. So this is the largest population which is being under the triple drug. So if you see, compared with the other countries, under under this triple drug, so 14 countries are implementing this triple drugs, and some countries the entire areas means under master drug administration, and some countries a few packets like India, a few districts like India, and a few countries, in fact, they are using it as a kind of a preventive measure in the post-MD or post-surveillance methods. So here, if you see the total population, India contributes, India has 95% of the people who are under triple drug administration, and other countries, it's only 5%. So we are the major consumer of ivermectin and also the new strategy. And this is really a good move to achieve or to accelerate elimination in India. But what is important is that, so we need to have certain innovative methods of ensuring that we are able to achieve the good coverage. Because few rounds, if you do not have a good coverage, particularly if you have considerable number of non-compliers, systematic non-compliers, it means that never taking the tablet, then that will be a problem. Like, so particularly if it is in the the high risk group, then it will be a problem. So what we have to do is that we need to have 2 the monitoring aspects. One is the monitoring on the coverage monitoring on the complaints. So we have a tool, supervisors coverage tool, so which in fact that we have to implement this during the round of MDA. And then suppose if you come across, because this is a rapid method, if you come across that the area requires, it means it is not achieving that 65% coverage, then of course we need to have mopping. So it means this has to be done every implementation, every the drug distributor area, so that be left with the optimal coverage. This is very important. This is some kind of should be an inbuilt the system within the program, so that we can achieve in all the areas the required level of coverage. Then of course we need to have some independent assessment, so that will be at the district level to make sure that we have achieved good coverage. Then this all about the strategies and the programs. And now finally, then we have to have some kind of monitoring and evaluation, which is an inbuilt component of program implementation. This is important because these are the two aspects. One is the monitoring. It means looking at the performance of the program in terms of the process. It means that we have the some targets in delivering our goods and whether we are able to do that. And second thing is evaluation, nothing but the impact. So here the transmission assessment survey protocol is being used to make a decision on stopping MDA, to see that whether we have achieved the total interruption of transmission that is based on the incidence of infection. So this is the basis for a decision to stop MDA. And also once you stop MDA, the same protocol is being used for the transition to post-MDA surveillance. So it means the task is repeated twice after taking decision based on the task one. So this actually designated, this protocol is to measure whether the evaluation unit have lowered the prevalence of infection to a level where recrudescence is unlikely to occur, particularly when in the absence, when you don't have any MDA intervention. So this is a kind of a safe level so that we can stop your intervention. So this the guideline is available, and this was revised in fact 2011, and this is made available for the program to make decisions. So this is nothing but a decision-making tool telling or indicating when to stop MDA, because it's a program, it's a time-bound program, but the point for stopping MDA is that to achieving the total interruption of transmission. And this is a standardized survey with robust but yet practical statistical design, because the sample size and the sampling design is so robust, and but with the statistical significance. Then uses children as an indicator of incident of infection, because we know that whatever the survey we do, it tells about the prevalence because it's a long-standing infection. But what we need to know is you have an intervention, and if you really achieved a total interruption of transmission, then of course it should be based on incident. And to measure incidence, it is the children who were born after the introduction of MDA are considered as the people who are totally protected, and the infection in this particular age class will be an indicator of incidence. Then, of course, this tool, the transmission assessment survey tool, measures whether the prevalence of infection is at or below the threshold. It means a critical cutoff at which the transmission assumed no longer sustainable in the absence of MDA. So this tool is widely used, and of course, these all the guidelines which are available at these sites, the WHO sites, and also we have the facilitator guide for training. And also we have another document, and particularly if an area fails in a transmission assessment survey, how to respond to that particular situation and what is the checklist. So this was the WHO guidelines, particularly related to transmission assessment survey and monitoring and evaluation of the program. And this particular monitoring is very important. If you just look at this particular graphical representation, in the absence of intervention, what you'll have is you'll have a stable prevalence of infection. It means the transmission will be at the stabilized level. So if, for example, if it is a 10% of the people having the infections, that will continue because you have recruitment of cases and you have loss of infection. So that balances it and becomes a stable in the absence of any intervention. So naturally this will occur and it will be on the stable condition. But what we do that when we have master administration, or rather a strategy based on preventive chemotherapy, so you give the treatment. It means treat the entire population, eligible population, once in a year, and you repeat the treatment annually. So what is expected is that for every treatment, so you can see reduction in the parasite load in the community. So this reduction increases. It is a cumulative kind of thing. Like, so when you repeat for 5 to 6 rounds of MDA, then of course what we expect is it should reach below the critical level, and the critical level is R0. It's nothing but the net reproduction rate. Net reproduction rate is nothing but the number of females produced by a female. If the number of females produced by a female is more than one, then of course it will increase in the in the incidence or the prevalence of cases. So that's what normally happens. But when you have a control pressure, what we expect is that R0 should be less than 1. If it is less than 1, then automatically this infection dies off. So here it is critical when you take a decision, then the R0 should reach below the 1. Unless otherwise you ensure that it is reached below 1, then of course likely, even if, I mean, after you stop your MDA, if your decision is not proper, then of course there is a possibility of resurgence of infection. So monitoring and evaluation, application of the transmission assessment survey protocol is critical in making a decision on that. So these are some of the potential tools to assess the master administration, reduces the parasite load, aiming at interruption of the transmission. So to make sure whether we have achieved the interruption of transmission, of course that we have to go by the monitoring the infection either in the human or in the adult, in the vector. So of course, Dr. Hoti mentioned about all these the different the tools, or rather the biomarkers which can be used to assess the impact. So here I want to emphasize two things. Number one is that, of course, we can look at the parasite maybe by microscopy, or you can just indirectly looking at the product of the parasites. That's the antigen which is detected by the ICT or OG4C3, or now if it is FTS. This is in case of the Uchrera bancrofti. But this will not identify the antigen of Brucia malai, and Brucia malai, it is the antibody test, and that is available to detect the exposure of the people to the infection. So these are some of the markers which are available and it's being used for the program. Then if we just look at the network, framework for master monitoring and evaluation, this is actually a generic framework for the neglected tropical diseases. Then if you just look at the target of the program is elimination as public health problem, and of course the extended target is that elimination of transmission. So of course it starts with the mapping, and if an area has more than the critical level or threshold level of infection in terms of microfilariasis or antigenemia, then we have to initiate master administration. And then if you use 3 drugs, so of course 3 rounds of MDA is sufficient enough. And then of course once you have the evidence that you have reached the total interruption of transmission, then of course we have to go for post MDA surveillance, and that of course based on 3 assessments using transmission assessment survey. But of course your monitoring and evaluation continues, and then of course once you achieve, it means all the areas cleared transmission assessment survey 3, and then of course the country has to develop dossier. It means claiming that the country has reached the total elimination, the total interruption of the transmission with no new infection, and then WHO examines and then provides a kind of acknowledgement to the claim of elimination of lymphatic filariasis. But we have to remember, this is elimination as a public health problem. But after that, in fact, that we have to have some minimal surveillance activities, what we call it as post-validation surveillance, and monitoring certain epidemiological indicators. And then, of course, we have to demonstrate that elimination of transmission, it means the 0 incidence. It means there is no case in the area where these interventions were carried out. So this is as far as the master administration is concerned, and this is in fact the target of elimination as a public health problem. And finally, elimination of the transmission, it means a 0 case. So of course, morbidity management, it has to continue. As I mentioned, that minimum package of care has to be continued, and this, in fact, we had to continue until the last case is line listed in the area. So these are the different stages, of course, which I have mentioned. And this is a process. In fact, the process are nothing but the validation. Validation is that we have demonstrated total elimination, I'm sorry, interruption of the transmission, and verification is that zero transmission. So this is the protocol. So the area of evaluation is the evaluation unit. Of course, the size of the evaluation unit is not more than 2 million, because this strategy is applicable, is valid only for an area having the population of less than 2 million. So then the survey has to be conducted. It means that after it meets the criteria, the eligibility criteria for transmission assessment survey is that the 5 effective rounds, because the recommended rounds of MDA are 5 for two drug regimen with the 65% coverage. So when you say effective rounds, it means unless you have 65% coverage, that is not considered as effective rounds. So make sure that all the rounds you have 65% coverage. Then the impact of the drug administration is that reduction in the parasite prevalence. It means the prevalence of infection in terms of microfilariasis. Also, you can measure in terms of antigenemia. That level is 1% for MF and 2% for antigenemia. And it has to be done at least 6 months after the last round of MDA, because the effect of these drugs will be there for at least 6 months, in the sense suppression of the microfilarial production. So it means that if you really see that the worm load, it has to be done after 6 months. And of course, target population is 6 to 7 years, as I mentioned. That's because we are looking at the incidence, and the incidence means this particular year 6 to 7, it means those who are born after the introduction of the master drug administration, and also who are totally protected under the program. And diagnostic tests, in fact, it's more sensitive. Point of care diagnostics is being used. And of course, this was mentioned by Dr. Hoti also. For the program for Uchera Bancrofti, that the Filariasis test, what we call it as FTS, is being used. Earlier, of course, ICT, and now that is replaced by the FTS. And these diagnostics are supplied by the WHO at free of cost. And for brucia, wherever you have brucia, either Timori or brucia Malay, then we cannot use the FTS or antigen test, but you have to go for the antibody test, which is known as brucia rapid test. That's being used, and you have the critical level to take a decision. Then survey design is the cluster sampling design. Suppose if the population is less, then of course you can go for systematic sampling, either in school and the community, and these methods can be used. And to make sure the transmission is not sustainable in an evaluation unit, and the indicators are less than 2% antigenemia for Q-likes on Anopheles transmitted area, and less than 1% for antigen, for Aedes transmitted area, because Aedes are considered to be more potential in the transmission because of the more contacts with the human within a single gonotrophic cycle. So probability of the transmission is higher in the Aedes. Then for brucia, of course, it is, as I mentioned, antibody, it is less than 2%. So then, of course, when you have this level, below this level, then of course MDA no longer required, and it's considered, TOS is considered as passed. So these are the diagnostics used. Of course, MF during the pre-TAS assessment, and then FTS for TAS, and then for antibody test for brucia area. And so then, to make it very simple for the program managers to determine that how many schools or the communities we have to do, and what is the critical cutoff, what is the sample size, and then what is the sampling fraction. So all these things. So you have a software that software will tell you all these the details, in the sense the number of sites to be visited and all. So what you have to do is, so we have to have some kind of input information that's on the number of schools, and also number of children in the age class 6 to 7 years, and also the non-response rate, and that will automatically identifies the number of the cluster, the schools to be visited, number of children to be screened, and also including the cutoff. So this actually gives, and also now it is an integrated survey sample builder. The soil transmitted helminthiasis has also been included, because we know the target population is school age children, and since the TAS is targeting 6 to 7 years children, and the same age class we can look for the soil transmitted infection. And as we know that it has got the LF elimination program has got a collateral benefit on TAS. So it means that the integrated evaluation will be much useful when you have school-based or community-based survey for LF and SDH. And so then coming to the scope for vector control, this is very important. As we know, preventive chemotherapy is the principal method of controlling and interrupting the transmission. But at the same time, when you have vector control as a supplementary measure, I'm not saying that vector control as a exclusive measure, but it is a supplementary measure, then it means that the impact would be much more when compared with the preventive chemotherapy, either with the 2 drugs or 3 drugs alone. So here, of course, the interruption is not only targeting the parasite in human, but also in reducing the transmission by having vector control. So the WHO position statement on vector control for lymphatic filariasis is also there. It means that it recommends wherever possible that we can have the vector control, then that will have more effect, particularly in countries where the burden is heaviest. So India is one of the countries where the burden is heaviest. So, of course, in other countries where you have certain problems related to the mass drug administration, then, of course, vector control can be a good supplement to eliminate lymphatic filariasis. So, and again, the WHO position statement on integrated vector management for malaria and lymphatic filariasis. So, it says that we know that malaria, we have 2 important the component. One is the vector-based intervention, and another is the case detection and treatment. So, vector-based intervention is particularly endorestrial spraying and then use of LLINs. So this vector of LF, mostly the Q-legs and Anopheles, they are the night biting mosquitoes, and also it bites, and the peak biting is after the people retire to bed. It means after 10 o'clock or so. So it means whatever the protection offered for the vectors of malaria, the same kind of protection we can expect for the vectors of LF. So what is required is that how that is some efforts to strengthen this vector-based intervention for malaria to cover the lymphatic filariasis also. So when you have malaria elimination or malaria control program, and of course some more effort, it will be useful to make the filariasis elimination programs so much more effective. And also this statement, the urges the stakeholders or the partners to support the program wherever we have this kind of integration of the malaria and as well as the lymphatic filariasis. Then, of course, where we can say other than the malaria, where you have the malaria program, because that is actually, it's a collateral benefit we can consider, but we can strengthen that by having more efforts on that. So, but at the same time, vector control as such, we can consider certain situations that it has got some kind of significant effect. One thing is the hotspots. As we know, it is a clustered disease. So within the districts or within any area, so may be certain areas where we have more risk and of course more cases. So those areas that can be identified. So when we do transmission assessment survey, certain sites with antigen positive children can be identified, that can be considered as hotspot, and those areas, so we can have vector control, so that will stop in the resurgence of infection. Then the area where you have the scope for vector control is the urban situation. As we know that there is always a low compliance when compared with the rural area. This low compliance, that we can compensate low compliance with vector control. And we know the vector control is with the local bodies, particularly, the corporations, municipalities, and the panchayats. So probably if we strengthen the vector control, then we may be able to achieve or accelerate LF elimination. Then prevents resurgence or reintroduction in areas with the persistent infection after stopping MDA. And also post-validation phase, if you get some signal in the community that there is likelihood of resurgence of infection, then immediately that we can stop the transmission by implementing vector control. Then, of course, now triple drug regimen, the monitoring and evaluation protocol has been developed by the WHO, and of course, this is a provisional guideline. There's just 2 slides I just mentioned. For India, it is very important because, as I mentioned, that many of the districts have completed 2 rounds of MDA. At this stage, of course, we have to do some kind of monitoring to take a decision on stopping MDA. So this is the pre-task. So here, when compared with the transmission assessment survey, which have been recommended for 2 drugs, these are the different steps. First thing is the goal of the pre-task assessment is that measure the impact in the worst situation. It means that's the in the sentinel sites. So it means that when you see the impact, the required impact or required level of impact in the worst situation, that we can expect the same level of impact in other areas. Then eligibility criteria is, of course, now the specified rounds of MDA, particularly based on the program settings as outlined by the WHO, either 1 round or 2 rounds or 3 rounds, so depending on the situation. So we need to have the effective rounds of the coverage. It means 65% coverage. And once it's done, of course, as I mentioned, that it should be supported by the independent assessment of the coverage by external agencies. Then evaluation size, unlike for the 2 drug, the transmission assessment survey. So here it is the 5 lakh population. It means it has been downsized, the evaluation unit. Then sampling strategy is 2 sites per every 5 lakh population. And then again, these 2 sites should be the worst situation. It means that the high risk areas. Then the sampling is a convenient sampling. It means that taking the highest, the area with the highest or greatest risk, and at least 300 population per site. And the sampling population, unlike in the 2 drugs, it is both gender but the higher age class, the 20 years and above. Whereas for the pre-TAS for 2 drugs, it is actually 5 years and above. So it means that we can expect that 20 years and above, they are high at high risk of this thing. So we can expect a high prevalence in this particular age class. Then indicators, of course, biomarkers is microfilaria, or the microfilaria is the one, but of course we can do FTS or the Brucha rapid test to see the infection, and those who are positive for FTS or that's antigen or antibody, then they can be smeared for microfilaria. And then decision, of course, less than 1% for Anopheles and Culex, and 0.5% for Aedes for the pre-task qualification. And coming to the task, here the EU size is 5 lakh population, and the target age class is adults aged 20 years and above. And then selection of the clusters. So again, this is based on this survey sample builder, and the sample size is 3,500. Unlike it's just off for the transmission assessment survey for 2 drugs. And then, of course, you have both the cluster sampling and the systematic sampling depending on the size of your evaluation unit. And diagnostics test the same, FTS for Wichita Bangrafta and the Brucha Rapid for Brucha Malai. And these things in the extended survey is that checking these positives for microfilaria. So because that our decision is going to be on the prevalence of microfilaria. Then threshold for decision is, there are 2 criteria. Number one is that the average prevalence of microfilaria in the EU is less than 1%, particularly in the Anopheles and Culex area, and 0.5% for Aedes area. And it considers the upper one-sided 95% interval, confidence interval. The other important mandatory, the criteria is that no single cluster, because it's a 30 cluster sampling, and no single cluster has an microfilaria prevalence that's more than 1%. That, and of course, this considers the lower 95% confidence interval. So this, in fact, is a provisional guideline which has been developed by the WHO, and now this is being piloted in many countries. So I think probably India is also involved in the piloting of this, the new monitoring and evaluation for the triple drug intervention. Thank you.